Next speaker is Ingerid Reinertsen, a senior research scientist and research manager for the group Medical Image Analysis in SINTEF Digital. She has a master in engineering from France and then a master in medical physics and a PhD in biomedical engineering from McGill University in Canada. And today she will talk about AI-assisted brain tumor surgery. So please.
Thank you very much. Thanks for the nice senior research scientist and research manager at SINTEF Digital in Stavanger. I'm also associate professor at the Norwegian University of Science and Technology and and today I'm going to take you inside the operating room and we'll explore a little bit what AI can do in the context of surgery as soon as we get the mic going. Oh, good. All right. So this is my research group. We're 10 people working exclusively on medical image analysis, so all sorts of medical images. Today I'll show you mostly MR images, but we have large projects on digital pathology, on ultrasound, on OCT images, all kinds of medical images that you'll find in a hospital or a clinical setting. So let's dive into brain tumors. So this is kind of the overview. There are more than 1,000 new primary brain tumors in Norway per year. The most common and the most aggressive ones are the glioblastomas. There were 265 of those in 2024. For these tumors, the median survival is about 15 months after diagnosis. That's when we apply everything we have in terms of modern cancer therapy. So those are the really aggressive ones. We also have the really silent one, benign ones that can be resting there for decades. Today we'll mostly focus on the aggressive ones, the ones that end up in surgery. So these tumors are treated with surgery, with chemotherapy, and with radiation. So brain tumor surgery is a very fine balance between removal of tumor tissue and preservation of healthy tissue. There's a very close relationship between the amount of tumor removed and the survival. And the MR images of the patients are the most important source of information for diagnosis and planning of surgery. So MR images of brain tumors can look like this. Brain tumors look very differently in MR images. They can be, let's see if I have a pointer on this. No. So to the left you see a huge one with a big black hole in the middle, which is a necrosis, basically dead brain tissue, rim enhancing structure. So this is typically a very aggressive tumor, fast growing. Next to that one, you can see a tumor in between the eyes, so white structure in there. This is a meningioma. It's a benign tumor, but the location and the mass effect of that tumor is not optimal because it touches the optical nerve and may cause vision disturbances and blindness. And over to the right side, there's a very little meningioma, a little white structure on the right side. This kind of tumor these are often incidentally discovered. So the MR image is taken for some other reason, and then you discover a little brain tumor in there, and once it has been discovered, it has to be followed. And sometimes these tumors don't move for 10 or 15 years, and then all of a sudden they can start growing. So these are examples of tumors, and they all look very different and have to be analyzed and treated differently. So what the radiologists typically do when they look at these images is they, of course, they count the tumors, they characterize the appearance, so intensity, enhancing or not. They look at the size, maybe they measure the size, they characterize the anatomical location. Do we have any overlap with critical structures? Do we have any the placement of the tumor in the brain? Is it going to be operable? Can we operate this tumor? And if we have some other images of the same patient, we might look at the growth or the evolution over time. A challenge is that we don't have any standardized reporting system. The radiologist will write this in his or her own words, which can make it difficult to compare between radiologists, between surgeons, and between centers. So this is where AI can help us. AI can give us accurate quantitative measures. It can be a lot faster than the radiologist. No variability, same images out, same measurements, same image in, same measurements out. And of course, the AI models are available 24/7 and don't go on vacation or home early on a Friday afternoon. So what we're doing is that we do the image-based analysis and we create a report for the surgeons. So I apologize for this slide being in Norwegian, but the important number here is the 98 at the top. This is the percentage of included brain tumor patients in our local registry in Trondheim. This registry was created in 2015, and as we cover a defined geographical area of Norway, this means that we basically have all brain tumor patients in that geographical area, and that we have a population-based database, which is super important in terms of biases in our analysis. But while Trondheim is a small city, so we need to scale up and we need to collaborate with others. So over the years, we have collected, now I think it's close to 10,000 patients from other hospitals in Europe and the US, which is super important for this kind of analysis and to make sure that the results generalize well to other centers. So the first thing we do is to do MR sequence classification. This, of course, the MR sequence can be found in the header of the image file in the PACS system at the hospital. Our experience is that that can't really be trusted, and this, the quality of that data is very variable. So we have developed or trained MR sequence classification to keep things in order in our database. This works very well with a recall of 98.3, precision 98.8. So that was good. That was a first step. Next thing was to do a tumor type classification. Also works quite nicely. So then we have both the tumor type and the type of image. And we can start doing real work. The segmentation before surgery is quite straightforward, a task that has been worked on by many groups for many years. But it's an important baseline to have to work on images from later time points. So here we do all the major types of brain tumors. And we create a report with the volume, laterality, resectability, distance to critical structures, all the information that the surgeon needs before surgery. So then we go into surgery. This is an image from the operating room at St. Olav's Hospital. I've taken this image, and not because it's a great image, but just because I need to highlight that it's important to be there to see what's going on, to understand the data, to understand the clinical situation, understand the surgeon's questions, concerns, and obstacles during the operation. Then afterwards, the patient has usually, they take new MR images the day after surgery. It can look something like this. And the classical way to measure this residual tumor, which is the tumor that is still there after surgery, is to do sum of a product of perpendicular diameters. So it's illustrated in the image here. I think we can all agree that there are some weaknesses in that method. And this is also used to determine progression. So when you have follow-up scans, they are measured in the same way. And a rule of thumb says that a 25% increase equals progression. That 25% comes from, and this corresponds to a 40% increase in volume, assuming that the tumor is a sphere. So that means that the tumor has to grow substantially before it's discovered by this method. So what we've done is to develop algorithms to do better. So do post-operative segmentations. Here we worked on a data set with nearly 1,000 early post-operative MRIs, where we've done classification if there's a residual tumor or not, and segmented the residual tumor if it's present. And as you see, the DICE score, which is the overlap measure, is substantially lower than for the preoperative tumors. This is to be expected, as these are small and fragmented lesions and much more difficult to segment. So what we do again is to create a report at the postoperative stage, where we compute the extent of resection, which is an important prognostic factor for these patients. We compute the volumetric evaluation, and we compute the RANO assessment, which is the clinical guidelines for these tumors, these patients. So this is the RANO categories. As you see, there are some volumetric cutoffs that we can identify and classify based on the MR images. And what has been shown by several groups is that this classification between 1 and 4 has implications for patient survival. So the more tumor is removed, the longer the patient will live. So this is from the original study, but there are several validation studies of these guidelines going on, and something that is very a hot topic in the clinical environment. For our study on postoperative segmentation, we wanted to compare our segmentation algorithm to neurosurgeons and radiologists. So we had 8 doctors annotate 20 images. And you can see that from this box plot, where you have the novices in green, the experts in blue, and the AI models in pink, that the automatic segmentation is not significantly different from the manual annotations and produces segmentations on par with clinical experts. We also did a clinical validation where we included close to 800 patients, where we investigated the prognostic value of the extent of resection and the volume of the residual tumor. And we concluded that the automatic and manual measurements have comparable prognostic value. It's important to note that manual measurements here means manual segmentations, and that's not what's going on in the clinic. In the clinic, we have the diameters that I showed you previously. So the automatic method here could be a clear step forward in terms of accuracy for these measurements. So in summary, we have a pipeline where we have inputs from the preoperative stage and from the postoperative stage. We do classification of both tumor types and MR sequences. We do segmentation using all different images, residual tumor, resection cavity. I didn't talk about that, but we do that also in the postoperative images, and also flare, the flare signal in non-contrast enhancing tumors. And then at the end, we produce the surgical report, both at the preoperative and the postoperative stage. So all this has been put into an open source software called Radionics that you can find online, and that is regularly updated with the latest models and the latest, our latest results. So with that, a few words about the future work. We're going into multimodal AI. So for many of these patients, we also have the electronic health records, we have the pathology images, and that can be fused and to make predictions about prognosis and future growth. And we're also working on AI models that can handle more than one tumor type at one time point at the time. We need broader models that can do more. So that's a topic for new research projects. So the group includes both clinicians and engineers from NTNU, from St. Olav's Hospital, and from SINTEF. Thank you very much.
Thank you so much. And I think we have room for at least one question, if any.
Yes and no. Well, depends on the challenge. I think BRATS was one of the first big ones, one of the first that really provided a large data set, and I think it enabled a lot of research and drew a lot of attention to this problem. So in that sense, many more people were working on this because of that data set. But then comes back to the data. I think most challenges are as good as their data. So the BRATS data set from the beginning was large at that time. It has evolved a lot, and it became better. Still, it's mostly, well, they have evolved a lot. It changed basically every year for 10 years. But at least in the beginning, it was mostly images from high-resource US centers. And I think the organizers acknowledged that after a while also, that they needed to cover more areas. They have now a for example, a challenge on sub-Saharan Africa, where we see a completely different image quality. And we see that the models developed on, in prestigious US hospital, not necessarily generalized well. So I think that challenge has been important for this field, but still there's a lot of work to do, and especially on the after treatment situation and follow-up.